ACLS Test 2026 AHA Pretest 40 questions answers April updated. Question 1. A patient is in cardiac arrest due to suspected drowning. What is the priority regarding the airway? Option A. Do not provide breaths, use only compressions. Option B. Establish a secure airway and provide ventilations early, as hypoxia is the primary cause of arrest. Option C. Wait 5 minutes before giving any breaths. Option D. Perform abdominal thrusts to remove water. The correct answer is option B. Establish a secure airway and provide ventilations early, as hypoxia is the primary cause of arrest. Unlike primary cardiac arrest, drowning is a hypoxic event. Early ventilation and oxygenation are critical. You should follow the standard ABC or BAC sequence rather than compression-only CPR. Question 2. A pregnant patient, over 20 weeks gestation, is in cardiac arrest. What modification should be made to CPR? Option A. Perform compressions on the abdomen. Option B. Perform manual left uterine displacement, LUD, to relieve aortocaval compression. Option C. Place the patient in a 45-degree side tilt. Option D. Do not perform CPR on pregnant patients. The correct answer is option B. Perform manual left uterine displacement, LUD, to relieve aortocaval compression. In late-stage pregnancy, the uterus compresses the inferior vena cava, reducing venous return. Manual LUD, pulling the uterus to the patient's left, is preferred over a tilt to maximize the effectiveness of compressions. Question 3. If ROSC is not achieved in a pregnant patient within 5 minutes of arrest, what procedure should be considered? Option A. Immediate discharge. Option B. Perimortem cesarean delivery, PMCD. Option C. Stopping CPR. Option D. Increase epinephrine dose to 5 mg. The correct answer is option B. Perimortem cesarean delivery, PMCD. To save both the mother and the fetus, a PMCD, emergency C-section, should be initiated within 5 minutes of the start of maternal cardiac arrest if there is no ROSC. Question 4. A patient in cardiac arrest has a suspected opioid overdose. What is the role of naloxone in this scenario? Option A. It is the first-line treatment for cardiac arrest. Option B. It is secondary to high-quality CPR and defibrillation. Do not delay CPR to give naloxone. Option C. It should be given before the first shock. Option D. It is not used in ACLS. The correct answer is option B. It is secondary to high-quality CPR and defibrillation. Do not delay CPR to give naloxone. In full cardiac arrest, naloxone is unlikely to be effective because there is no circulation to transport it. Standard ACLS, CPR, shocks, epinephrine, takes priority over naloxone. Question 5. Which of the following is the recommended first dose of magnesium sulfate for pulseless Torsades de points? Option A. 1 to 2 G4/IO bolus diluted in 10 ml. Option B. 5 G4 push. Option C. 10 GIM. Option D. 100 mg bolus. The correct answer is option A. 1 to 2 G4/IO bolus diluted in 10 ml. For pulseless Torsades, magnesium is given as a rapid bolus. For Torsades with a pulse, it is given as an infusion over 5 to 20 minutes. Question 6. During a resuscitation, the team leader assigns you a role, but you are not sure what the specific tasks for that role are. What should you do? Option A. Pretend you know what to do. Option B. Wait for someone to tell you. Option C. Ask for clarification. What are the specific tasks for the recorder role? Option D. Stay silent and watch others. The correct answer is option C. Ask for clarification. What are the specific tasks for the recorder role? Clear communication in team dynamics requires that if a task or role is unclear, you must ask for clarification immediately to ensure the resuscitation continues smoothly. Question 7. After a patient achieves ROSC, how long should you wait before performing a formal neuroprognostication, determining brain death/recovery potential? Option A. 12 hours. Option B. 24 hours. Option C. At least 72 hours after return to normothermia. Option D. Immediately. The correct answer is option C. At least 72 hours after return to normothermia. Accurate neuroprognostication should be delayed until at least 72 hours after ROSC, and after the completion of TTM, to allow the brain to stabilize and medications to clear. Question 8. A patient in ROSC is being ventilated. The PECO2 is 25 mmHg. What is the likely effect on the brain? Option A. Improved blood flow. Option B, cerebral vasoconstriction and reduced blood flow. Option C, no effect. Option D, reduced risk of seizures. The correct answer is option B, cerebral vasoconstriction and reduced blood flow. Hyperventilation, lowering CO2, causes cerebral arteries to constrict. This reduces blood flow to the brain, which can worsen post-arrest brain injury. Question 9. In the ACLS tachycardia algorithm, what is the initial energy dose for a synchronized shock for unstable atrial flutter? Option A, 10 to 20 joules. Option B, 50 to 100 joules. Option C, 200 joules. Option D, 360 joules. The correct answer is option B, 50 to 100 joules. Atrial flutter and SVT typically respond to lower energy levels, 50 to 100 joules. Atrial fibrillation usually requires higher energy, 120 to 200 joules. Question 10. Which medication is an alternative to amiodarone for the treatment of shock-refractory VF/private? Option A, atropine. Option B, lidocaine. Option C, adenosine. Option D, dopamine. The correct answer is option B, lidocaine. Lidocaine, 1 to 1.5 mg/kg first dose, is an equally effective alternative to amiodarone for the treatment of VF and pulseless VT. Question 11. What is the maximum total dose of lidocaine during a cardiac arrest resuscitation? Option A, 1 mg per kilogram. Option B, 3 mg per kilogram. Option C, 5 mg per kilogram. Option D, 10 mg per kilogram. The correct answer is option B, 3 mg per kilogram. The maximum cumulative dose of lidocaine is 3 mg per kilogram. This usually consists of an initial dose and up to 2 follow-up half doses. Question 12. Which reversible cause of arrest is most likely in a patient who was found in a house fire? Option A, hyperkalemia. Option B, hypoxia and toxins, carbon monoxide/cyanide. Option C, hypothermia. Option D, tamponade. The correct answer is option B, hypoxia and toxins, carbon monoxide/cyanide. Smoke inhalation victims often suffer from hypoxia and toxins, CO and cyanide. Cyanide toxicity may be treated with hydroxycobalamin during the resuscitation. Question 13. A patient in stable SVT has received adenosine 6 mg and 12 mg without conversion. What is a reasonable next step? Option A, shock the patient at 360 J. Option B, give a third dose of adenosine 18 mg. Option C, consult an expert and consider a calcium channel blocker, example, diltiazem. Option D, give atropine. The correct answer is option C, consult an expert and consider a calcium channel blocker, example, diltiazem. AHA guidelines only recommend 2 doses of adenosine, 6 mg then 12 mg. If these fail, the clinician should switch to rate control agents like diltiazem or beta blockers after expert consultation. Question 14. What is the recommended dose of procainamide for stable wide complex tachycardia? Option A, 1 mg per kilogram. Option B, 20 to 50 mg per minute until the arrhythmia is suppressed or the max dose is reached. Option C, 300 mg bolus. Option D, 100 mg/min. The correct answer is option B, 20 to 50 mg per minute until the arrhythmia is suppressed or the max dose is reached. Procainamide is infused at 20 to 50 mg/min. The max dose is 17 mg per kilogram. It should be avoided in patients with a prolonged QT interval or heart failure. Question 15. When should you use an oropharyngeal airway, OPA? Option A, in any patient who is sleeping. Option B, only in unconscious patients with no gag reflex. Option C, in conscious patients with a stroke. Option D, to prevent snoring in alert patients. The correct answer is option B, only in unconscious patients with no gag reflex. An OPA will stimulate the gag reflex and may cause vomiting and aspiration in conscious or semi-conscious patients. It is only for deeply unconscious patients. Question 16. How does a nasopharyngeal airway, NPA, differ from an OPA regarding the patient's level of consciousness? Option A, an NPA can only be used in unconscious patients. Option B, an NPA is better tolerated in patients who are semi-conscious or have a gag reflex. Option C, an NPA cannot be used in adults. Option D, there is no difference. The correct answer is option B, An NPA is better tolerated in patients who are semi-conscious or have a gag reflex. NPAs are softer and do not stimulate the gag reflex as intensely as an OPA, making them useful for patients who are not fully unconscious. Question 17. What is the priority when the monitor shows a narrow complex P rhythm? Option A, defibrillation. Option B, searching for mechanical causes like hypovolemia, tamponade, or tension pneumothorax. Option C, giving amiodarone 300 mg. Option D, giving a 360J shock. The correct answer is option B, searching for mechanical causes like hypovolemia, tamponade, or tension pneumothorax. Narrow complex P is highly associated with a lack of volume or obstruction, the H's and T's. Finding the cause is the only way to save the patient. Question 18. Which drug should be considered for a patient with a known beta blocker overdose in cardiac arrest? Option A, atropine. Option B, glucagon. Option C, amiodarone. Option D, lidocaine. The correct answer is option B, glucagon. Glucagon is the specific antidote for beta blocker or calcium channel blocker toxicity and may be used during ACLS if these toxins are suspected. Question 19. In the ACLS stroke algorithm, what is the goal for a door to neurologist consultation? Option A, 10 minutes. Option B, 20 minutes. Option C, 45 minutes. Option D, 120 minutes. The correct answer is option C, 45 minutes. The stroke team/neurologist should be involved and a decision regarding fibrinolytic therapy should be made within 45 minutes of the patient arriving at the hospital. Question 20. What is the correct dose of aspirin for a patient with suspected ACS? Option A, 81 mg, 1 baby aspirin. Option B, 162 to 325 mg, chewed. Option C, 650 mg, swallowed. Option D, 1000 mg 4. The correct answer is option B, 162 to 325 mg, chewed. A dose of 162 to 325 mg of non-enteric coated aspirin should be chewed to ensure rapid absorption and antiplatelet effect. Question 21. If a patient has a pulse but the rhythm is ventricular fibrillation, what is happening? Option A. This is impossible, VF is by definition a pulseless rhythm. Option B. The monitor is broken. Option C. The patient is fine. Option D. The patient is having a heart attack but not an arrest. The correct answer is option A. This is impossible, VF is by definition a pulseless rhythm. VF is a chaotic quivering of the ventricles with no organized contraction. It is impossible to have a pulse in VF. If you feel a pulse, the rhythm is not VF. Question 22. A patient has irregular, wide complex tachycardia at a rate of 140 bpm. They are alert and have a BP of 120/80. What should you do? Option A, immediate cardioversion. Option B, adenosine 6 mg, if regular and monomorphic, or amiodarone 150 mg infusion. Option C, check for a pulse. Option D, start CPR. The correct answer is option B, adenosine 6 mg, if regular and monomorphic, or amiodarone 150 mg infusion. For a stable patient with regular monomorphic wide complex tachycardia, adenosine can be used to help diagnose/treat, or an antiarrhythmic infusion, amiodarone/procainamide, can be started. Question 23. When using transcutaneous pacing, what is the output, or MA, used for? Option A, to set the heart rate. Option B, to set the electrical current strength needed to achieve capture. Option C, to check the battery. Option D, to shock the patient. The correct answer is option B, to set the electrical current strength needed to achieve capture. The MA, milliamperes, is the strength of the electrical pulse. You increase the MA until you see a pacer spike followed by a QRS, capture. Question 24. A patient is in cardiac arrest. IO access is established. You are about to give epinephrine. How does the dose change from the 4 route? Option A, give double the dose. Option B, give half the dose. Option C, the dose is the same as the 4 dose. Option D, IO doses are given every 10 minutes. The correct answer is option C, the dose is the same as the 4 dose. 4 and IO doses are identical for all ACLS medications. Question 25. A patient in ROSC is having a 12-lead ECG. The ECG shows a right bundle branch block. Does this patient require an immediate cath lab? Option A, yes, immediately. Option B, no, unless there is also ST segment elevation, STEMI, or other signs of acute ischemia. Option C, yes, all bundle branch blocks need a cath lab. Option D, only if they have a headache. The correct answer is option B, no, unless there is also ST segment elevation, STEMI, or other signs of acute ischemia. While a new left bundle branch block, LBBB, can sometimes be treated as a STEMI equivalent, a right bundle branch block, RBBB, alone is not a criteria for emergency PCI unless ST elevation is also present. Question 26. What is the first step in the ACLS, bradycardia with a pulse algorithm? Option A, give atropine. Option B, identify and treat the underlying cause, example, maintain airway, give oxygen, monitor ECG/BP. Option C, start pacing. Option D, give epinephrine infusion. The correct answer is option B, identify and treat the underlying cause, example, maintain airway, give oxygen, monitor ECG/BP. Before giving drugs, you must assess the patient, support their ABCs, and determine if the bradycardia is actually causing the symptoms. Question 27. What is the correct second dose of atropine in the bradycardia algorithm? Option A 0.5 mg, option B 1 mg, option C 3 mg, option D 5 mg. The correct answer is option B, 1 mg. Atropine is given in 1 mg doses every 3 to 5 minutes, up to a total of 3 mg. Question 28. A patient in P arrest has suspected toxin ingestion. What should the team do? Option A, give amiodarone. Option B, provide prolonged CPR and consider specific antidotes or extracorporeal CPR, ECPR. Option C, stop the code after 10 minutes. Option D, give atropine. The correct answer is option B, provide prolonged CPR and consider specific antidotes or extracorporeal CPR, ECPR. Arrests caused by toxins often require much longer periods of resuscitation and specialized care, like a heart-lung machine or ECPR, while the toxin is cleared from the body. Question 29. What is the primary sign that high-quality chest compressions are being provided? Option A, the patient is waking up. Option B, PECO2 is consistently above 10 to 20 mmHg. Option C, the patient is sweating. Option D, the ribs are breaking. The correct answer is option B, PECO2 is consistently above 10 to 20 mmHg. Waveform capnography, PECO2, is the most objective measure of the blood flow being generated by chest compressions. Question 30. A patient has a heart rate of 190 bpm and is experiencing severe shortness of breath and a BP of 80/50ths. What is the priority? Option A, give adenosine. Option B, search for a reversible cause. Option C, synchronized cardioversion. Option D, vagal maneuvers. The correct answer is option C, synchronized cardioversion. Instability, hypotension and SOB during tachycardia always defaults to immediate synchronized cardioversion. Question 31. When should vasopressin be used in the cardiac arrest algorithm? Option A, before epinephrine. Option B, after amiodarone. Option C, it is no longer included in the AHA ACLS algorithm, use epinephrine instead. Option D, every 5 minutes. The correct answer is option C, it is no longer included in the AHA ACLS algorithm, use epinephrine instead. Vasopressin was removed from the ACLS algorithm in 2015/2020 because it offered no advantage over epinephrine alone. Question 32. A patient in cardiac arrest has a PECO2 of 45 mmHg after 2 minutes of CPR. What does this likely indicate? Option A, ROSC has occurred. Option B, the patient is dead. Option C, the tube is in the stomach. Option D, hyperventilation. The correct answer is option A, ROSC has occurred. A sudden jump or high level of PECO2, 35-45+, during CPR is a strong indicator that the patient's heart has restarted, ROSC. Question 33. Which of the following is a role of the team leader? Option A, perform all the compressions. Option B, assign roles, monitor performance, and provide a summary of the code every few minutes. Option C, wait for the doctor to arrive. Option D, do all the writing. The correct answer is option B. Assign roles, monitor performance, and provide a summary of the code every few minutes. The team leader maintains a bird's-eye view, ensuring everyone is on track and providing global summaries to help the team reevaluate the H's and T's. Question 34. During a code, a team member notices the rhythm has changed from P to VF. What should they do? Option A. Wait for the next 2-minute check. Option B. Interrupt immediately and say, the rhythm has changed to VF, so a shock can be delivered. Option C. Give epinephrine. Option D. Do nothing. The correct answer is option B. Interrupt immediately and say, the rhythm has changed to VF, so a shock can be delivered. This is knowledge sharing. If you see a major change that alters the algorithm, like a non-shockable rhythm becoming shockable, you must announce it immediately. Question 35. A patient is in ROSC. Why is it important to avoid hyperoxia, excessive oxygen? Option A. It causes the patient to stop breathing. Option B. It creates oxygen-free radicals that can damage brain tissue after a period of ischemia. Option C. It is too expensive. Option D. It prevents the heart from beating. The correct answer is option B. It creates oxygen-free radicals that can damage brain tissue after a period of ischemia. While we give 100% oxygen during arrest, after ROSC, too much oxygen can cause reperfusion injury to the brain. Titrate to 92 to 98%. Question 36. What is the first-line treatment for a patient in stable atrial fibrillation with a heart rate of 140 bpm? Option A. Defibrillation. Option B. Rate control, example, diltiazem or beta blockers. Option C. Atropine. Option D. Epinephrine. The correct answer is option B. Rate control, example, diltiazem or beta blockers. For stable AF, the goal is to slow the heart rate down using medications. Cardioversion is usually elective or reserved for unstable patients. Question 37. Which heart block is also known as Wenckebach? Option A. First-degree AV block. Option B. Second-degree Mobitz I. Option C. Second-degree Mobitz II. Option D. Third-degree AV block. The correct answer is option B. Second-degree Mobitz I. Mobitz I, Wenckebach, is the rhythm where the PR interval gets longer and longer until a beat is dropped. Question 38. A patient has a heart rate of 40 bpm and is unstable. Atropine has failed. You are starting transcutaneous pacing. At what rate should you set the pacer? Option A. 40 bpm. Option B. 60 to 80 bpm. Option C. 100 bpm. Option D. 120 bpm. The correct answer is option B. 60 to 80 bpm. The goal of pacing is to restore a normal heart rate and blood pressure. Setting the pacer at 60 to 80 bpm is the standard starting point. Question 39. You are the team leader. You notice the team is becoming disorganized and loud. What should you do? Option A. Yell louder. Option B. Assign a safety role to a team member. Option C. Call for quiet in the room and provide a summary of where you are in the algorithm. Option D. Stop the code. The correct answer is option C. Call for quiet in the room and provide a summary of where you are in the algorithm. A good leader maintains mutual respect and order. A global summary helps refocus the team and lowers the noise level. Question 40. What is the most important factor in surviving an out-of-hospital cardiac arrest? Option A. A fancy hospital. Option B. High-quality CPR and early defibrillation. Option C. The type of ambulance used. Option D. The patient's age. The correct answer is option B. High-quality CPR and early defibrillation. ACLS is an advanced layer, but the foundation that actually saves lives is the immediate start of high-quality compressions and rapid use of an AED/defibrillator.